Welcome to another just-in-time video from Rap'em. Today we're talking about pediatric high-flow nasal cannula protocols with Dr. Mary King. She's a pediatric intensivist from Seattle, where she's the medical director of the trauma ICU at Harborview, and she's also an intensivist at Seattle Children's, and associate medical director of the Washington Medical Coordinating Center, where she was in charge of setting up protocols for pediatrics during last year's tripledemic. Mary King, thank you so much for joining us.
You're welcome. Thank you so much for having me here, Jonathan.
It's great to have a real authority in how to manage tripledemics here because we are again in viral season. And while it hasn't met last year's peaks, I think everyone wants to be ready for that sick kid that comes into their rural emergency department. So let's talk about one of those kids. You've got a 1-year-old kid with an upper respiratory infection for a couple of days. They've got increased work of breathing. They're on 12 liters of high flow in your ED. And you call your normal pediatric referral center and they say, we would love to help you, but we are full to the gills. Now what do we do?
Yeah, that's the question that everybody asked last fall for sure. And I expect it to happen again, but it may not be for the next couple months, hopefully. Well, you need to start with understanding some data about your high flow nasal cannula patient in your hospitals. So from a patient standpoint, one, you've already told me child is on 12 liters of high flow nasal cannula. That's one thing. It's how much high flow. Also, from a patient standpoint, we need to know if there are any potential complicating medical factors. Is this a former preemie? Does the child have pulmonary hypertension? Child have congenital heart disease, etc. Now, from a hospital standpoint, we need to know what hospitals are capable of. So, high flow nasal cannula at one hospital is not necessarily the same as high flow nasal cannula at another. So that's why it's really important to know our high flow nasal cannula protocols at all the hospitals in our region. And we need regional visibility of those protocols. We also need to know if there's a pediatric acute care ward, potentially a pediatric hospitalist, and or if there's an ICU in that hospital that could potentially back the patient up if the child gets sicker. For higher risk patients, we're probably going to want them to have closer access to an ICU. And then also we'll need to know about transport agencies, whether they have the capability to transport a child on high flow nasal cannula. That came up a few times last fall.
Yeah, so in a state like Washington where there's centralized data, there's universal reporting, and you can sort of know at a real-time level what's going on, air traffic control style at every hospital in the state. I imagine that's an easier lift. And in some places, don't have that infrastructure. It might literally be just have a list of what hospitals are capable of accepting patients to their ward, who has NICUs, who has PICUs, and which transport companies are capable of doing high flow nasal cannula rather than swooping into your emergency department and intubating your child.
Definitely. I also think you would want a list of those high flow nasal cannula protocols because we found, certain places were willing to deliver 1 liter per minute per kilo, whereas other places were willing to deliver up to 2 liters per minute per kilo. So it really varied. And if you don't know that as a sending facility, you're going to make a lot of phone calls unnecessarily. So if you can have that information as well, I think you're set up to start making some better decisions for your patients. And once you do that, you can actually go through a process of kind of figuring out kind of lower, moderate, or higher risk patients and figure out which environment would suit them better. So for a lower risk patient, they could potentially get ongoing care in place, maybe with some telehealth or phone consultation ongoing. Or they could go to a pediatric acute care ward without ICU backup on site. But maybe for a moderate risk patient, they would go to a pediatric acute care ward with pediatric hospitalists that also has ICU backup. So either a PICU or maybe for an infant, they'd have a NICU with some higher level high flow or CPAP capabilities. And then there might be some higher risk patients that really should only be in an ICU.
And how do you make that determination? How do you decide which category those kids fall into? Or is that a decision you have to make on your own in a small rural emergency department? Or is that something you're going to be talking to your referring centers about?
Yeah, I think that's a really good question. I think it starts with having the data about your patient and the hospital. Um, so once you start with that data, then you can have that meaningful conversation. And so, yes, it could be having that conversation with your pediatric center. Um, or in some instances, if there is a mock, it could be having that conversation with a pediatric nurse who's on the phone for a mock. And sometimes they have a pediatric SME backup as support. So, for instance, in Washington State, our PICU attendings served as consults for our nurses, our triage nurses that were taking the phone calls. So sometimes if there wasn't enough information, we might ask for some more information to help make a better decision.
Great. So let's make things a little bit more complicated. I'm going to take that same 1-year-old, I'm going to make them 3 months old, but I'm not going to change anything else. So now it's a 3-month-old on 12 liters of high flow nasal cannula. So they've gone from being, half a liter per minute to 2 liters or more per minute. How does that change your thinking about where these kids could go under normal circumstances? And then, as we all know, under the not so normal circumstances that we sometimes find ourselves in?
Yeah. Now, you're bringing back a lot of memories for me for last fall. So those were really stressful phone calls to get about these infants. Um, and I think we have to recognize that those are higher risk situations and that those children need to be in an ICU. And a rural ED is not a pediatric friendly ICU setting. And so then, given that, we have to think differently about our ICU resources. Um, is that infant able to be cared for in a NICU? There are many NICUs in our state who stepped into taking care of small infants with bronchiolitis last fall. And so I think leaning on our NICU colleagues in situations where we may be faced with a large number of critically ill infants is necessary because there is nowhere else for them to go. Then the other thing would be thinking about the children that are in PICUs. Are there kids that could be cared for in adult ICUs? Maybe there are teenagers with overdoses going to pediatric ICU beds that really shouldn't be because they could be getting care at 16 or 17 years old in an adult ICU somewhere. So I think we have to think about all of our capacity as a region. And that depends on calling on our colleagues for help sometimes.
That's such a great point. I think it's just so critical as we face another viral season this year and then again next year and the year after, to just remember that we need to be actively thinking about where these kids can go, getting creative about where they can go, and working together to have both that visibility about available options for placement, but also what the acuity of these children are and what different places are capable of handling. Because as you've said, the community is where the capacity often lies for these kids if we can get them safely somewhere where they can get adequate care.
I agree, Jonathan. I will make one point here too, is that even if you don't have a pediatric mock, just having visibility of the data in and of itself is sometimes enough to help people lean into the problem. Many of our NICU colleagues, once they saw how many critically ill infants were in rural ERs, that's all it took for them to start actively admitting these kids. So I would say step one is try and obtain and share the data.
Fantastic. Mary King, thank you so much for joining us. Thank you for your expertise. Thank you for everything you've done for RAPM and for the state of Washington. You've put together a beautiful one-pager on this. That'll be available as a link off of our YouTube page where you can also find other just-in-time videos from RAPM. Thanks so much.
Thank you so much for having me.